Welcome to MenopauseWize, your go-to podcast for all things evidence-based in the menopauseverse. I am Dr. Sukhpreet Patel, an MD gynecologist, a menopause health advocate, a postmenopausal woman, and the founder of MenopauseWize. And I'm so excited to have you join us on this journey. Whether you're a healthcare provider looking to stay on top of the latest evidence-based practices, a woman navigating your own perimenopause or menopause journey, or a partner or family member eager to support a loved one, this series is designed with you in mind. Our mission through MenopauseWize is to close the menopause knowledge gap by bringing you the latest research, expert insights, and practical advice, empowering you to make informed decisions about menopause and perimenopause. Hello, and welcome to today's episode of the MenopauseWize podcast on taking GLPs. Hello, and welcome to today's episode of the MenopauseWize podcast on taking GLPs. Don't forget your bones with Dr. Susan Bryan. Dr. Bryan is a board-certified endocrinologist with nearly 2 decades of experience in endocrine and metabolic health. She practices at the Cotton O'Neill Diabetes and Endocrinology Center in Kansas, where she combines clinical care with research as an investigator at the Cotton O'Neill Clinical Research Center. Dr. Bryan has held leadership roles, including chair of the Department of Medicine at Stormont Vail Health and president of the Heartland chapter of the American Association of Clinical Endocrinologists. She has served as principal investigator on numerous clinical trials and continues to advance endocrine care through her dual commitment to clinical practice and research. Hello and welcome to today's episode of the MenopauseWize podcast on taking GLPs. Don't forget your bones with Dr. Susan Bryan. Dr. Bryan is a board-certified endocrinologist with nearly 2 decades of experience in endocrine and metabolic health. She practices at the Cotton O'Neill Diabetes and Endocrinology Center in Kansas, where she combines clinical care with research as an investigator at the Cotton O'Neill Clinical Research Center. Dr. Bryan has held leadership roles, including chair of the Department of Medicine at Stormont Vail Health and president of the Heartland chapter of the American Association of Clinical Endocrinologists. She has served as principal investigator on numerous clinical trials and continues to advance endocrine care through her dual commitment to clinical practice and research. Thank you, Dr. Bryan, for joining us today and for helping us understand the impact of GLP-1s on bone health. So we're aware today the verdict on the GLP-1 medication seems to be quite clear with regards to metabolic health, with diabetes, with weight, and it seems to be helping a lot of people. And in this podcast, we mainly focus on women.
Yes.
But an area that's sometimes forgotten is bone health, and that's the area that we're focusing on today. And could you start with helping us understand the relationship between body weight, weight loss, and bone loss or bone
Yes.
health?
It is actually kind of complex.
Mm-hmm.
First of all, because they don't always correlate someone's weight and how dense their bones are on imaging and their fracture risk, for example.
Mm-hmm.
So we say there's an obesity paradox in that patients with, say, for example, type 2 diabetes with obesity tend to have stronger bones on bone mineral density imaging and yet have a higher fracture risk because their bone quality is more poor, likely from vitamin D deficiency and other obesity related things in the bone structure. So it doesn't always correlate. So first of all, just your weight and your bones. But in general, the more mechanical loading that your bones experience, which is weight is one of those ways that you mechanically load your bones, the more pounding you get, the more pulling from the bigger muscles and pulling on the bone, the stronger your bones are going to be. So more typically, when you are heavier and have more muscle mass, you will have more bone density. But again, it doesn't always mean quality of the bone. So that's kind of a different thing to remember and think about. So for anyone, when they lose weight, they are losing that mechanical load on that. They don't have as much weight to be pounding the bone, and they're you often lose some muscle as well, and so you're not pulling on the bones as well, so that mechanical loading is different. And so for anyone losing weight, you can lose bone density through that mechanism, not just by not mechanically loading the bone as much. And that's how just general weight loss, bariatric surgery weight loss, and the GLP-1 medications, that's how they can be associated with bone loss, any type of weight loss.
And so what I hear you say is the J-shaped relationship of
Yes.
weight with
Yes.
bone density, because
Yes.
leaner women are also more prone to
Yes.
lower bone density. But you're saying
I would say
that
not bone density, but fracture risk, the
fracture risk.
J-shaped curve with fracture risk, because some patients with obesity can have strong looking bones on bone density, but still have a higher fracture risk because of quality being
Right.
poor.
Right. And so that was going to be one of my following questions, the dissociation between bone density and fracture risk, because so often we get caught up with bone density on our DEXA scan that we're not really looking at. What are we looking at? We're not just looking at our bones for strong bones or for a report card. We're looking at how do we prevent ourselves from actually having a broken bone, right? So we'll come back to that in a little
Right.
bit. And so now, this was weight loss and looking at bone health. Now let's put in another layer of GLP-1s. Do they impact bone health or bone density or fracture risk? Is it indirectly through weight loss or is it directly through other mechanisms?
That's an excellent question. And in preclinical studies, you can see that GLP-1 medications, there are receptors for GLP-1 medications in the bones. They do directly affect the bones, but it's opposite of what you think. They actually have an anabolic or a bone building effect directly on the bone. So a lot of people thought they were actually going to improve bone density because they stimulate the osteoblasts to help build bone, and they help inhibit the osteoclast from breaking down bone. So that's what they actually do ex vivo, and in animal studies you can see that. However, that's not what we've seen clinically. We see the risk of bone loss, and so we don't think it's a direct effect. They do directly affect the bones, but not in a negative way, in a positive way. But that could not be overcome by weight loss. And so we really do think the weight loss is the main issue when it comes to losing bone with anything and GLP-1 medications. Also, we see that the patients who tend to have the worst bone loss tends to be our patients, and a lot of these are observational studies, so they're not the best studies, but what we've gathered from observational studies is that tends to be the patients who are on GLP-1 medicines for weight loss, who are losing more weight, because remember, GLP-1 medications for someone with type 2 diabetes, you just don't lose as much weight. You often have to go to higher doses, and you don't have as much weight loss, probably because of the more metabolic disease in patients with type 2 diabetes. And there also might be a resistance to GLP-1. We know that there's actually a deficiency of GLP-1 in patients with type 2 diabetes. But so they're not losing as much weight. So the patients losing more weight in the obesity studies with GLP-1 are the ones who tend to have more bone loss. And so we do think, again, it's a weight loss effect because we're seeing it more in the obesity trials than we are in the type 2 diabetes trials.
Wow, that's really interesting. That is extremely interesting. So of course, so many layers, right? We're talking about first the impact of body weight, and now you've explained to us GLP-1. And now let's add a third layer of perimenopause, because that's what our audience mainly is here.
Yes.
And we're looking at women in perimenopause approaching us often with the problem of weight gain, with an increase in visceral fat and an increase in metabolic health changes which are unfavorable, and so resorting to GLP-1s.
Yes.
And this is the same population that is at high risk for bone loss. And so how do we navigate this, and what do you have to say to these women before they get started?
That's an excellent point, that in that population, in menopause, perimenopause, you start losing bone density probably 2 years before your final period.
Mm.
So in perimenopause, you are starting to lose bone density. And then the first several years of menopause, you are, kind of rapidly losing bone density if you're not on hormone replacement therapy. And so that is the time most in a woman's life where you
Mm.
will most quickly lose bone density, is that transition, perimenopause, postmenopause years. And so now, just like you're saying, that's also the time where cardiometabolic disease starts increasing. So like you said, visceral fat because of the loss of estrogen, risk of type 2 diabetes, et cetera. So that is a time when women often are benefited by GLP-1 medications, but you're putting that on top of this escalated bone density loss. So it can be a double risk for women
Mm.
in perimenopause, menopause who are going on GLP-1 medications. And the mechanism by which estrogen loss worsens bone density is the same mechanism by which you can lose bone density with GLP-1s, in that estrogen stimulates the osteoblasts to build up bone,
Mm.
and it also inhibits the osteoclasts from breaking down bone. So you can have that same mechanism happening with the weight loss, because the osteoclasts are revved up in weight loss to break down the bone. The osteoblasts that build the bone are actually linked to the osteoclasts. So
Mm.
um, yes, it's an interesting mechanism where they're both doing negative things. So that's one reason that estrogen in this period of time, we like it, and it's actually FDA approved for the treatment of osteopenia to prevent osteoporosis,
Right.
because when you give estrogen back, you help the osteoblasts work better and you inhibit the osteoclasts.
Right.
So it is a unique time of increased risk because you're losing estrogen, and
Mm.
if you are losing weight with the GLP-1s, you're also
Mm.
having that extra mechanism for bone
Mm.
loss.
And it's about the latency between this bone loss and actual fractures, which
Yes.
gets unnoticed. Because for a woman in perimenopause, let's say if I'm 48, which I'm not, but let's say I'm 48, going through perimenopause, and I am putting on weight. I want to get on a GLP-1, which is helping me with my weight and my metabolic health. Um, and maybe I am taking care of my bones, maybe I'm not, but that bone loss is going to show up for me if I don't test now, only maybe a decade later when I do
Mhm.
fracture my hip or have a vertebral fracture, right? So, but my metabolic health and my weight, those are the two report cards that I'm going to get really quickly, because I'm going to
Mhm.
see the weight on the scale. I'm going to see my blood sugars and my lipid profile maybe get better, but I am not going to face
Mhm.
that fracture later, which brings me to checking bone density. Is that
Yeah.
something you would advise women
Yes.
to do?
Yes, yes. But to your point, I just want to agree that yes, this is a silent disease.
Mm.
You don't know you have osteopenia, developing osteoporosis. You don't know that. You don't have bone, there's no bone pain with
Yeah.
osteoporosis unless you have a fracture. Unless you're looking at the bone density, you do not know. So that is an excellent point, is that it is silent until it shows up as a fracture, or until age 65, which is the standard time where a bone density is recommended for a woman. At
Mm.
65, you get it and realize, wow, I have severe
Mm.
osteoporosis. I didn't know it. And I could have been doing something all these years about it, but I didn't know. So,
Yeah.
yes, technically the guidelines say that a woman should have a screening bone density at age 65, or earlier if she has risk factors for osteoporosis. Well, you can argue that menopause is a risk factor for osteoporosis. Certainly, if you put menopause with weight loss,
Yeah.
that is an added risk factor for bone loss. I order bone densities all of the time at menopause consults. When a woman comes to me for perimenopause or menopause consults, they're cheap. They're usually like around $100 out of pocket. But in my experience, I don't think yet I have had a insurance deny it. So I personally
Mm.
have not had trouble getting the first one covered. Usually there's enough of a reason that I guess insurance is covering it, but even if they don't, it's around $100 out of pocket, so pretty cheap. Very low radiation.
Yeah.
It's like an X-ray. So it is, I enjoy getting it when I'm seeing a patient in perimenopause or menopause consult, because it gives me a baseline for where we are. Also, something that's important for people to understand with bone density, I was a certified reader for a long time, and I run our bone fragility fracture clinic. So I see a lot of osteoporosis and fragility fracture, which a fragility fracture means that you have a fracture without trauma. You sit down and fracture your pelvis, or you have a small little fall and you fracture your hip. So some people never accrue bone density. You should, in your late teens and 20s, build your bone density, and then peak about 30 with bone density. And hopefully it's nice and strong, and then stay there. If you don't have any chronic conditions or malabsorption or, poor nutrition, stay there until menopause, perimenopause, menopause, when it starts going down. But if you've never had a bone density, if you've never had bone issues, you don't know actually how far you got up there. And so that's one thing when we get someone's bone density, like, we don't know, is this decreasing? Have you never gotten up that high? So part of that, what's interesting about getting a baseline, is kind of nice for the future too. And plenty of times the bone density is normal, and then we're reassured. Plenty of times it's osteopenia, and then that helps us make decisions about hormone therapy too, if we're kind of on the fence. And many times I have found osteoporosis when we've all been like, wow, that was really, surprising that someone didn't have as many risk factors as you would think. And those times you're thinking, well, maybe they never accrued that bone density, to begin with. So personally, I do like to get a bone density, and especially if we're going to institute a GLP-1, then you can get that baseline bone density. And there was just a paper written about, it was recommending that we reconsider doing a bone density a year after starting a GLP-1 and getting a bone turnover marker. Now, that's not there's no formal recommendation, but that's what this recent paper recommended, based on like a 2024 paper where they saw people that took liraglutide, which is Victoza, over a year, if they didn't exercise with that liraglutide, lost bone density. If they exercise with it, they didn't lose bone density, which I'm sure we'll going to get to that part. But so personally, I do like to get a baseline bone density, and then depending on, what happens, a follow-up. Insurance will not pay for a repeat bone density except every 2 years, unless you go on a new treatment, which you can consider estrogen hormone therapy, in which case they'll pay for it in 1 year for a repeat. But it takes the bones about a year, for sure 6 months, and about a year to change enough to see a difference. That's why it takes so long before we repeat the bone density. So I do recommend that, but that's the formal recommendation is 65, unless you have another risk factor.
I know, and that 65 sounds like it sounds pretty late, because by then you may just you missed the boat for a lot of things, including hormone therapy, because
Yep.
we're looking
exactly
at the
right.
60 less than 10 being your best window.
And seeing all the fractures in the fracture liaison clinic, I so many times have heard patients like, I had no idea. I had no idea I had osteoporosis. My first inkling was I fractured, and I wish we could back up 10 years ago, and so.
I know. Yeah, so that's a tricky one. You mentioned turnover markers.
Yes.
Would that be something that you routinely advise? Because 1 year is such a long time to wait for any impact on your bone density.
It does feel like a long time away. I do bone turnover markers in the bone clinic, that we run, because it is helpful. Typically they're just done in that setting or in research. But this recent paper was suggesting we consider like a C-telopeptide. C-telopeptide is a good blood test that looks for bone turnover. You're looking for basically those osteoclasts turning over, and then you can see that in C-telopeptide. So that's not standard of care, but certainly if you got a baseline, it would not be as helpful, I think, to just get a random one. You can definitely do it after you've been on it, but even more helpful, I think, is to see what a baseline would be, and then to see what it is on the GLP-1 medication, because that is looking for bone turnover directly. There's a lot of caveats with those, need to do them
I know.
fasting, and they're, they can change because of kidney disease and other sort of things. So
Right.
you do have to kind of know what you're doing when you're looking at them. But yes, they definitely can be helpful, and now are being discussed as whether they should be done. Um,
Yeah.
Especially if someone's losing weight rapidly.
Mm.
That in particular is what this paper was talking about. If you have someone who maybe already has those risk factors, thin, maybe history of smoking, family history of osteoporosis or hip
Mm.
fracture, risk factors, and they're losing weight rapidly, that would be
Mm.
a time you probably would say, okay,
Mm.
that especially heightened, maybe that would be a good time to check a bone turnover marker.
That's interesting. But coming back to doing a DEXA scan, let's say if we have someone with a BMI of, let's say, 38, so has a clear indication to be on GLP-1 medication, but now you did say, of course, weight will in some way give us a better bone density. How often are you seeing women with a higher BMI, let's say in the obese range, but have poor bone density during perimenopause?
It's
Is
not as
that a
common.
um,
Not as common. What is more common is if you have like a fracture with a better
mm,
BMI and you're surprised, wonder why this
mm,
person is fracturing even though their BMI looks pretty good, then typically there's a bone quality issue.
mm,
Other things that can cause poor bone quality are like vitamin D deficiency, which of course is more common in patients with obesity. So that's another thing we haven't touched on yet, but that GLP-1 medications,
mm,
bariatric surgery causing malabsorption, maybe you're not having as much of your vitamin intake because you're at
mm,
poor appetite or you're not absorbing it. So it's not as common to see that. You can, it's just more common to see a fracture that you're surprised about with a pretty good bone density. And then it's a quality issue there.
yeah, and I think that distinction is great. Thank you for bringing that out between bone density and fracture risk.
Yeah.
That's so important. Coming back to other risk factors, are there any other risk factors you would consider besides the bone density before getting someone
Mm-hmm.
started on GLP-1 agonist, particularly considering the bone?
Mm-hmm. Yes. For one thing is autoimmune conditions can be more commonly presenting at the time of menopause. And
Mm,
so thinking about, do they have celiac disease? If they have
mm,
Hashimoto's or another type of autoimmune disease, might we be missing celiac disease? And, you can screen for celiac. Sometimes we'll do a parathyroid hormone level. If there's vitamin D deficiency, you can get a secondary hyperparathyroidism, or if they have a low calcium. So there's a whole, we call it secondary osteoporosis workup, where you're looking at parathyroid hormone and vitamin D and celiac. And, so
mm,
there are definitely, I'm always just, endocrinologists, we love labs. So we're kind of
right.
looking through those things, but there's definitely a lot of other underlying conditions that can lead to osteoporosis. And if they have evidence of any of those, then certainly, not that you can't do GLP-1, but as you're saying, you should be, that should be thinking more about the bones and wanting to protect them.
Right. And I think the Frax is a great online tool as
Yes.
well that women can,
Yes.
physicians can also use. So
Yes.
that's something that we can use. But let's come to how do we prevent this bone loss? If I want to
Yes.
lose weight, I want better metabolic health on GLP-1 agonist, but I want to protect my bone. What is your advice for me?
Yes, exercise and
Mm,
nutrition. Exercise is the most important. And there's kind of two things that have been shown in exercise to improve bone density. And, a lot of things that just maintain bone density, like walking, walking
right.
is great. It's good for bone density. But to build bone density, which is if you're on one of these medications, certainly in menopause, we want you doing these two things to actually build bone. And one
Mm,
of them is it's the weight bearing, but it's even more than just walking. Walking maintains, but to
mm,
build, we tend to need jumping, hopping, skipping, more of a impact.
mm,
Now, a lot of people can't do that because of
mm,
arthritis issues or, just inability physically, patients who are in a wheelchair or whatever. So
yeah.
is some limitation, but if you're able, more of the pounding, and then the weight lifting or the resistance training is the other arm that can also build bone density. And for that, moderate resistance training at least 2 days a week, ideally 3. 20 minutes or so seems to be the amount of time. And when we say moderate resistance training, what we mean is if you're doing like 10 curls, with weight, by the time you get to 8, you should be like, oh, I don't know if I can do 9 or 10. You can do 9 and 10, but it's enough of an effort that you're wondering. That's how intense the weight should be. So any weight is great, but if you want to try to get to the moderate intensity level where we know that you're building bone and muscle, by the way, that's also the moderate intensity is where we get the muscle too. Then not just real light things that you feel like I could do this for an hour, that's good. And that has like a lot of good benefits too. But to build bone, it's the pounding and the moderate intensity resistance training. Those things, and when they did the great study where they added those two GLP-1 versus GLP alone, one alone and resistance alone, you will lose bone density with just the GLP-1 alone based on the good studies. But if you add the resistance training to it, you don't lose bone density, you maintain it. So, and of course, and those are good for all kinds of other things, like we're talking about muscle, metabolism, type 2 diabetes, so a lot of things that they help besides just the bone. But if you, ideally, you are agreeing to incorporate those in your life because you want the benefit of them, and that really does help avoid, in what we've seen so far, the negative effect of the GLP-1.
Oh, so what I
And it
hear
makes
you saying
sense
is,
if you're thinking about the weight loss causing less pounding, less resistance, you're overcoming that by
right,
doing more yourself.
right. And so lifestyle becomes inevitable whether you are on a GLP-1 or not.
It
And
benefits
that's
you all the time, but
mm,
all the more better reason to, especially if you can understand the reasoning behind why you should be doing it to help protect your bones from the GLP-1 effect,
right.
or the
And
weight
I think
loss
for
effect, I should say.
for a lot of women who have been struggling with weight loss and haven't seen results in the past and now begin to see results while they're on medication, perhaps it is more motivating for them to show
Yes.
up. What has your experience been
That
with
is
that?
exactly my experience. And
Mm,
that's why I, get bothered sometimes by a lot of the negativity that you'll hear. It's just a fake thing that they're doing, or they're not doing the work. That's not been my experience at all. My experience
mm,
has been people finally feel like I've been doing this thing, but not
mm,
seeing the same success. And now I'm seeing success still doing
right.
this
Yeah.
exercise, or now I feel like I can move my body better, because it lowers inflammation so well. GLP-1
Mm,
lowers inflammation so well. Now I feel like I can move so much easier. I'm much more active. I've seen that
mm,
so many times. Like, I
mm.
used to go on hikes, every weekend, and I'm doing that again. Or, I
Ah,
used to love the gym and now I'm going back. So yes, I've seen the opposite, that people feel better, and so they're more
mm.
apt to be more active.
And when we talk, you mentioned nutrition earlier, and I want to talk a little bit about it because we're constantly hearing, make sure you're having enough protein because
Yes.
protein is an important ingredient for your bone. But if my appetite's going to be suppressed,
Yes.
what can I do about that?
Yes, that's exactly an excellent point. So first, like for the bones, diet, exercise, this effective. Protein is also effective, but it's less effective. So the
Mm,
exercise is really so important, but the protein is also important. It's just not as important.
got
But yes, when your appetite is suppressed, then trying to prioritize the protein.
it.
And of course, you want vegetables and fiber and all of the
Right.
good things, but the protein is important. As we are getting older, we do start losing muscle, probably even in our 30s. And then
Mm,
it really ramps up in our 60s, 70s, 80s. But so that resistance training is the most effective for
mm,
maintaining that muscle. Protein is also important, just not as, but probably 1 to 1.2 grams per kilogram is kind of a great range to get it. You can go higher than that with some like bodybuilding sort of things, but like 1 to 1.2 is probably a good goal of us, grams per kilogram a day for women. And so if you can try to prioritize getting that protein in, which
mm,
for a lot of women ends up like 30 grams or so a meal, and
Right.
then maybe with a snack, trying to prioritize that when your appetite isn't as good, then putting those things first, or
Mm,
trying to get them in before you get full is definitely important,
right.
but not nearly as important as the resistance training. So, and I think
Absolutely.
that's what we get mixed up sometimes. Oh, I can just have a protein shake and then I'll protect my
Mm.
muscle. The resistance training is actually much more effective than that.
Uh, Besides all its other benefits of feeling
Right,
better,
exactly.
that yeah,
Yes.
exactly. Yeah.
Yes.
You mentioned something about vitamin D. Could you expand a little bit
Yes.
on that? Yes.
The calcium vitamin D thing is actually really tricky and complicated, but um, in overall, you want from the time you're little and building those bones to have good calcium vitamin D intake.
Mm.
And some people actually that have severely poor intake, because of some unusual diet that they had, or living situation where they couldn't access it, then they can get that osteomalacia, where that's the very poor bone quality because you don't have the substrate to build the bone to begin with. So calcium and vitamin D helps us absorb the calcium. They are very important. When we don't have enough calcium or vitamin D, our parathyroid glands get turned on and they increase our parathyroid hormone, which thins out the bone. It ramps up those osteoclasts. So it is all very important to bone. However, a lot of studies have shown that in the normal, healthy, regular population like us, calcium and vitamin D supplementation probably don't improve bone density or lower fracture risk. So it's important to get it in your diet. For the general population, you know, probably aren't benefited by supplementing with it. In the higher risk, older population who are institutionalized, is what they say, in a nursing
Right.
facility, long-term care facility, they often are deficient and often are benefited by supplementation to reduce fracture risk. There's actually
Mm.
some data that shows that high vitamin D supplementation, where your levels get high, or maybe it depends on a person and their absorption, but might actually increase fracture risk. So maybe on
Mm.
that J curve again. So
Mm.
I really maybe increase fall risk. Really interesting data. It
Mm.
is personalized. If you've had gastric bypass surgery, if you have other, short bowel syndrome or whatever, malabsorption, you can get severe vitamin D deficiency. That is poor bone quality. You need supplementation, sometimes high dose supplementation in our patients with Roux-en-Y gastric bypass, whatever. So it is individualized. And so you don't,
Mm.
I hate to ever make wide sweeping effects, but
Right.
statements, but the calcium and vitamin D is a trickier subject than what we often, or it's not just a one size fits all. And for most people, they they are not benefited by supplementation. Now, when you get to osteoporosis and treatment, they are typically benefited when you add it to
Mm.
Prolia or other medications. So
Mm. I did read that study on vitamin D supplementation, higher levels and increased fracture risk, and I was really surprised to see that.
yeah.
But I guess it is what it is. And would you then run vitamin D levels to check? Because how else does one make out that
You
that
don't you don't
right?
know. Yeah. Insurance doesn't cover it unless you have
Mm.
an indication for it, and the
Hmm.
indications are not very many that they cover it for. So usually you have to get one and often pay for it out of pocket to see if you have vitamin D. Once you have vitamin D deficiency, now that's a diagnosis where it's paid for to check your
Right.
levels so you can repeat it. But we always check it, of course, in our osteoporosis patients or our fracture patients. So I do check it a lot. It's more commonly deficient in patients with type 2 diabetes. If you have a low
Mm.
calcium in your lab, that is a strong marker that you have vitamin D deficiency. And hypocalcemia, is a reason that insurance will pay for a vitamin D level. So,
Mm.
but yeah, you don't know. You don't know unless
Yeah.
you check your level.
But would that be then justified in someone who's taking a GLP-1 agonist just because what if there isn't enough dietary intake of vitamin D?
Yeah, they actually did a recent study of vitamin deficiencies in GLP-1 users,
Hmm.
and the most common deficiency was vitamin D deficiency.
Mm.
But that has a confounding in that those patients who were on it for obesity. So probably obesity was caught. They probably
Mm.
had pre-existing vitamin D deficiency. It wasn't
Right.
probably not the probably the medicine wasn't causing it, although it could. But in general, when you lose weight, your vitamin D is going to be better because it's fat soluble, so you don't tend to need as much.
Right.
So yeah, I think it's not a bad idea. It's not a standardized recommendation, but
Right.
it certainly is going to help protect you if you have low D that you find and then can replace it.
Yeah, the thing about standardized recommendations is that they take so long to develop
I
and
know.
to put into effect that
Yeah.
a generation has gone through something without any kind of assistance. So, but anyway, that's good to know. What about adding another layer now of menopausal hormone therapy? Can they be
Mhm.
additive, the effect with GLP-1
Yes.
drugs? Mm.
Yes, two Mayo, they're small studies, but one with semaglutide, one with tirzepatide, showed that for weight loss, when you are using one of the GLP-1, if you add hormone therapy to it, then you can help further weight loss than just the GLP-1 alone. So we know they
Mm.
have some probably a little bit additive effects there for weight
Mm.
loss, but also it is a good, it is a great thing to come alongside as far as the bones, because when you go on estrogen, particularly in the menopause hormone therapy, the estrogen then protects you from bone loss, and it
Mm.
helps stabilize. You can get some improvement, but at least stabilize and not have the bone loss effects from menopause. Even the
Mm.
smallest dose of estrogen that we have, which is a microdose 0.014 milligram on the patch, even that microdose has been shown to protect bone loss. So
Mm.
even the tiniest amount of estrogen for hormone replacement therapy does have a bone protective effect. So that's another, so you can use them together to
Mm.
potentiate the weight, maybe based on,
Mm.
two kind of small studies. And certainly the hormone therapy can help offset likely some of the bone potential negative effects of the weight loss.
Right. The 14 microgram was the Meno Star, isn't it? Is it still available?
Yes.
Is it still
Oh, it
available?
is, you can still get, but what we most commonly do is we give them a
Cut.
0.025 and cut it in half. Yeah.
All right. Okay. And you know, coming to further about menopausal hormone therapy, if a woman is really symptomatic in perimenopause, perhaps she'll exercise more diligently if she's symptomatically feeling better, isn't it?
That's
So,
one of the theories about why adding hormone therapy to the GLP-1 in menopause might potentiate the weight loss effect. Certainly,
mm,
there's, estrogen helps improve estrogen sensitivity, so replacement, but just hormone therapy by itself doesn't tend to cause weight loss, but certainly if you're feeling better, and both hormone therapy and GLP-1s can help you feel better in different
mm,
ways. The hormone therapy is often helping you sleep better and having
mm,
less of the hot flashes and night sweats and joint pains. The GLP-1 often helps you feel better because of inflammation. And the
mm,
inflammation markers in two really good prospective randomized controlled GLP-1 studies showed the markers of inflammation in the blood test were lowered by about 48%.
wow.
And the inflammation starts tend to improve quickly. It's one of the
Mm,
things that even before you get substantial weight loss, you get that improvement in inflammation. And that's often, I think, what people are feeling even a few weeks into a GLP-1, where they're like, oh my goodness, things are changing. I feel
mm.
so much better. I think a lot of what they're feeling is that lowering of inflammation. So that's another way, yes, that both of them kind of help in different ways and can help people be more active because they feel better.
Oh, yeah. And what about, let's say you have a woman on a GLP-1 drug and it's been a year and you're seeing a deterioration in her bone densitometry. Would that be enough reason for you to pause her medication?
Um, I would look at a couple of things. One is like, what's the rate of weight loss that we're
Mm,
experiencing here? But that should really be done before a year. Um,
right.
if you're having significant weight loss, and some people will say that's more than 1% or so a week of weight loss. Usually it's more than 2 pounds for most people, 2 to 3 pounds a week. If you're having rapid weight loss, you should slow down the dosing. And
Mm,
how they're written, how these GLP-1 medicines are written is that you start on the lowest dose, 1 month later you increase it, 1 month later you increase it, 1 month later you increase it. So you are rapidly increasing it. And that's actually, it's so frustrating because insurance companies are, oh, they're looking for all the ways to deny it. This has happened to me, just happened to me yesterday. Insurance company, like, I want to stay at that first dose as long as it's working and as long as the patient's doing well. So this was a patient with diabetes. We were on the lowest dose of tirzepatide. Insurance says if you don't increase the dose to, so 2.5 is the first month, 5 is the second month, you're doubling the dose within 1 month. Insurance was saying we're not going to approve it because you're not escalating the dose on this patient. This happens a lot.
Really?
So I have to write, which I did yesterday, a letter to the insurance saying, no, we don't need to increase the dose. The patient is doing well. But yes, so it's harder almost to have the slower titration because of insurance and all their dumb stuff. But so if you followed what's recommended for the titration schedule, you would be ramping people up pretty quickly. So really, you should be watching from the beginning to make sure you're not getting all this weight loss, and then decrease the dose. You can decrease the frequency, whatever, a lot of different ways to do it. But yes, so a year later, I should have already been intervening, is my first point, that you should be watching how rapid that weight loss is and adjusting accordingly. But so a year later, I never think, unless there's some side effect, that I'm going to stop it because we're on it for a reason. They're doing well, but maybe lowering the dose. For sure, looking for other things that might be going on, especially if we haven't had much weight loss. Is there vitamin deficiency? Is there a secondary cause of osteoporosis going on? So most often I wouldn't stop the medicine, but I'm going to look for other things. Definitely try to avoid that rapid weight loss in the first place. Emphasize the exercise that we talked about, and then consider if we're on the borderline of whether we were going to do hormone therapy or not, have that discussion again. And then also consider treatment for bones, if depending on what the bone density shows and what their risk is. That's when you can start thinking about Fosamax or Reclast or Oniva or Prolia or whatever.
Right. What about monitoring body composition during these between DEXA scans? Is that routinely done?
It is not routinely done unless you're part of a clinic that has that. We have it in our research side of in our base med, but we don't have it for like our patients with type 2 diabetes or whatever. Our system has it. We have a bariatric clinic. So I try to get my patients to actually go to the bariatric clinic and have their GLP-1 done there if it's not a diabetes situation, because they do all of the body composition imaging. And then they do it at baseline. And then, as the weight loss is going, that is very helpful because you're looking at visceral fat, muscle mass, and then yes, you can follow it along to see, oh, we're actually gaining muscle, or we're not losing muscle, but we're losing the visceral fat. So body composition can be really helpful, but in my experience, it's not commonly done.
Because the muscle bone unit is so powerful as it is, right? So the muscle can actually give us such a huge window into what's going on in bone health. And would you have any idea about the numbers when we look at muscle loss? If are there any warning signals that we are looking at if we did have access to body composition?
Well, in the typical body composition research, when you're just losing weight without medication, then typically it's accepted that about 25% of your weight loss will be lean mass loss. And so that's kind of an acceptable amount. But again, you doesn't have to be. You don't have to lose any if you do that kind of moderate intensity resistance training. So 25% is the accepted. Above 25% is considered more than what is normal with diet loss. But again, none, you could say kind of no muscle loss is actually acceptable. In the GLP-1 studies, a lot of studies have around 30% of lean mass loss. The worst was a Wegovy study, which had 40% of the weight loss was lean mass loss. But a big caveat of all of that is that when you're looking at lean mass, that also includes a lot of things that's not just muscle. So it's not always an accurate picture. They also a representation of actual muscle loss. They also did this really great study last summer with tirzepatide and MRI imaging of the muscles in a randomized prospective controlled trial with tirzepatide. So the best kind of trial, they had an MRI muscle sub-study. And so in that, you could see that the muscles were decreasing in size, but they were fat infiltrated, bigger muscles with a lot of fat marbling that went to smaller, which that the size of the muscle, the amount of muscle mass to whatever weight they became, so their lower weight was normal. So it was a normal amount of muscle for that size of an individual, but less than what they had been. But also the muscle was higher quality. So it was a healthy muscle. And the other thing to note about that is that a lot of the studies, when they look at lean mass loss, which is what we say is like muscle loss, and physical function and strength, oftentimes you might see a lean mass loss, like maybe they're losing some muscle, but also can be other things in muscle, but they actually have a higher now physical function score and a higher strength score. So it doesn't always correlate that just because you're losing what appears to be muscle mass, which lean mass, you might be losing the fat marbling and actually gaining strength and physical functioning scores because it's a healthier muscle. You're feeling better, you're more active. So it's you have to understand, what they're looking at in a lot of these studies. So I think that's really reassuring. Of course, you don't want to lose muscle, but if you get better muscle quality and you actually get better physical functioning scores and more strength, then who cares,
No, absolutely. Absolutely. Yeah, so it just seems so nuanced.
It is very nuanced.
What kind of weight am I losing? And even if it
Yes.
is muscle, then what is the function of the muscle?
Yes.
And
That's why
it's
you really
amazing.
need to do it the right way. I think a lot of the reasons GLP-1 gets such a bad rap is that it's often done what I would say the wrong way, meaning escalating dose, losing weight really quickly, not knowing the things about muscle, composition, strength training, resistance training, not understanding the protein part, the nutrition part, going slowly. If you do it the right way, it has wonderful effects, but kind of done the wrong way, what I kind of say like the Hollywood way or whatever, I think that's what's giving them a bad rap in the public.
Right. Yeah, that's a good way to put it. That's a good way to put it. And ultimately, medicine is meant to be individualized, and it should be.
Yes,
Yeah.
always.
So, uh, great. I think we've covered most of bone health and GLP-1 agonists. Is there anything you think I missed out?
I think they were
Or is
excellent
that so?
questions.
Thank you. Thank you. Well, you were excellent at answering all of them. But just as a takeaway for our listeners now, women who are on GLP-1 agonists, maybe perimenopausal, maybe postmenopausal, basically in midlife, if you had 3 pieces of advice for them to take away, 3 practical pieces of advice, what would they be?
Yes, one would be, what's your bone density? Maybe consider
Mm,
asking for a bone density. Look at your risk factors. You can just easily Google risk factors for
mm,
osteoporosis, and you can then share that with your primary care doctor. Oh, did you know my mom had a hip fracture and I
mm,
had, X, Y, and Z? And so I'm concerned that gives that primary care doctor or whomever, oh, okay, this is a good reason to order a bone density and see what your bone density is. The second is
mm,
to think about body composition, exactly as you were saying, to work on the things that we know protect the muscle and the bones. And
mm,
a lot of that is that moderate intensity resistance training. And then you can add the hopping, skipping, jumping, which is also beneficial for the bone. So make sure you have the exercise piece in it, which is also good for your brain and for your risk of diabetes,
mm,
cardiometabolic,
mm,
all heart, all the things. And then the third is nutrition.
mm,
So making sure what you do have is quality so that your intake has the good healthy protein. Also, ideally, you're getting your good amount of fiber, vegetables, Mediterranean type of diet for health. So what is your baseline? What are your other risks? Look at them and evaluate them, maybe get a bone density, and then make sure you prioritize the muscle building and the bone building activities, and then the nutrition. Those are my 3
Wow.
top tips.
Wonderful. That was powerfully packed. So thank you so much for this,
You're
and I
welcome.
really appreciate how generous you've been with sharing your knowledge, and I'm sure this will help a lot of women on
Thank you.
GLP-1 agonists
I hope
maintain their
so.
bone health. Thank you.
Thanks.
Thanks again for tuning in to MenopauseWize. Stay informed, stay empowered, and I'll see you in the next episode as we continue to navigate the menopause journey together. If you're a healthcare provider interested in collaborating with us or have insights to share, we'd love to hear from you. Please email us at info@menopausewize.com. That's wise with a Z. And before we go, a quick medical disclaimer. The information provided in this podcast is for educational and informational purposes only and is not intended as medical advice. Always consult your physician or a qualified healthcare provider before making any decisions regarding your health or any medical treatments discussed in this podcast. While we strive to provide accurate and up-to-date information, this podcast does not replace professional medical consultation, diagnosis, or treatment. If you have any concerns or symptoms that require medical attention, please seek advice from your healthcare provider.